Thank you for attending the NEPO, or Network of Ethnic Physician Organizations, special topic webinar today. This webinar is scheduled for 1 hour, 12 p.m. to 1 p.m., entitled Inequities in Dementia Detection and Cognitive Health Assessments, Primary Care Dementia Screening and Diverse Older Adult Populations. This webinar will be recorded. My name is Jennifer Turner, and I'm the Chief of Operations for Physicians for a Healthy California. Next slide. Just some basic housekeeping. Attendees are in listen-only mode, however, may use the questions chat feature for any questions or comments for the speakers. Time has been allocated for questions and will be supported at the end of the presentation. Here at PHC, next slide, we are dedicated to improving community health, growing a diverse physician workforce, and promoting health equity. I mentioned NEPO, which brings together ethnic physician organizations from across California to advocate on behalf of their patients and communities. The goal of NEPO is to improve access to care, end health disparities, support practice improvements, and create a more diverse physician workforce. This webinar is sponsored by Union Bank. Next slide. Next slide. Today you will hear about the scope of the problem, better understand how to conduct a cognitive health assessment, learn about research and the future of closing gaps and disparities, obtain some key resources, and have the ability to ask questions. I'd like to recognize Lupe Alonso Diaz, our PHC CEO and President, Mary Maribel, our PHC Associate Director of Strategic Initiatives, and Ron Springard, Dementia Care Aware Director for Alzheimer Association, for making this webinar possible and helping foster the relationship with our amazing speakers today. Also, a big thank you to Union Bank for sponsoring this webinar. I'd like to also acknowledge our three highly knowledgeable speakers that you will hear from today. Dr. Anna Chodos from UCSF Division of Geriatrics, Dr. Charles Wyndon from UCSF Memory and Aging Center, Stella Della Pina from the Alzheimer Association. And without further ado, I'd like to introduce Dr. Anna Chodos.
Thank you so much. I can speak for myself and the other panelists today. We're really honored to be here. Really appreciate the introduction and just honored to be a part of the PHC efforts and NEPO efforts to bring more attention to health disparities. In this case, for all of us, myself, Dr. Wyndon, and Stella de la Pena, we are very dedicated to work around the issue of dementia and care for people living with dementia. So we really look forward to bringing you this presentation today. And we're all going to go back and forth and we're going to try to do it seamlessly. So we appreciate your attention and really looking forward to some of your questions. If you can, feel free to put them in the chat or the questions function and we'll get to them at the end. We're going to do our very best. So let's get started. Please forward. We have no disclosures. Next slide. So this is us, this is your panel today, and we all have a different role. We briefly were able to go over where we're coming from and why we're here today, but just to add a little extra to that, Ms. De La Pena is the Director of Diversity, Equity, and Inclusion at the Alzheimer's Association, which has decade-long history of advocating for people living with dementia and their care partners and support system. Dr. Wyndon is a clinical neurologist who works in dementia behavioral neurology and is at the Memory and Aging Center and also at UCSF as an assistant professor. I'm also at UCSF and I'm a geriatrician, and Dr. Wyndon and I work together clinically with people living with dementia and doing diagnosis and care. And I'm also really fortunate, you're gonna maybe see this logo here, Dementia Care Aware, to represent that initiative where I'm the executive director, and we're working right now and really look forward to any opportunities we can create for you or partner with you to do better dementia care in primary care. That is the focus of Dementia Care Aware, and lots of opportunity to check out what we're doing on our website, which we'll show at the end, and we have an email that we'd love you to get in touch with us. But one of the big goals is for the work around screening and detection to address health disparities that we're seeing here in California around dementia. Next slide, please. So now I'm going to pass it to Stella de la Peña, and thank you so much for talking to us about the issues of health equity.
Yes, thank you so much, Dr. Chodos. And I think health equity is something that we're talking a lot about these days, right? And we know that in regards to dementia care and Alzheimer's disease, there are a lot of disparities that we need to look at and think about and plan for the future. And so today we're going to talk more about how health equity plays into Alzheimer's disease and dementia and the future of what Alzheimer's and dementia can be with the help of all of our medical community, and it's going to take all of us to be able to make that difference. So thank you so much, Dr. Chodos. Next, please. And so when we talk about Alzheimer's disease, I'd really like to start by sharing a little bit about the prevalence and impact of Alzheimer's in California. So every year, the Alzheimer's Association releases a national and statewide facts and figures report on Alzheimer's disease. Last year, the association included a special report on race and ethnicity in Alzheimer's in America and showed some really important findings, some of which I will share with you today. So currently, there are over 690,000 individuals over the age of 65 living with Alzheimer's disease in California. This amount is expected to increase to over 840,000 by 2025 and is expected to double by 2040. When we think about our current population in California, which is around 40 million, and is expected to expand by 16% by 2040, the number living with Alzheimer's disease will grow 127%, which is astronomical. California, as you know, is one of the most ethnically and culturally diverse states in the nation. And so Alzheimer's disease is expected to disproportionately impact diverse communities. By 2024, more than 3 times for Latinos, nearly 3 times more for Blacks, more than 2 times for Asian American Pacific Islanders, and more than 2 times for LGBTQ Californians. When we think about mortality rates attributed to Alzheimer's disease, as the largest increase in the leading cause of death in California, almost quadrupling between 2000 and 2018, moving Alzheimer's disease to the 3rd leading cause of death in California in 2018. So as California continues to live longer, death due to Alzheimer's will continue to increase. Next slide, please. So when we think about capacity, right, and we think about dementia care and where people might turn for specialized care, we know that there are not enough neurologists and there are not enough geriatricians to meet the needs of the patients and for this rapidly growing disease. Especially when you think about our state having the largest average lifespan of more than 80 years, which shows that this is a real opportunity to help with detection and support patients during the earliest stages of the disease. Next slide, please. In our work at the association with our health systems initiative that was launched a few years ago, some of our national work that's also taking place in California, we've had the opportunity to work with a lot of health systems. And as a result of that, we've been able to hear routinely what some of the challenges are and that exist for you and others in your field in regards to improving dementia care. These are some of the most common challenges that we are often engaged with when working with our health systems accounts throughout California. There's a lot of constraints within the system, time constraints, lack of incentives, lack of internal resources, capacity issues. These may resonate with some of you. Next slide, please. Equally, we hear from patients and caregivers who reach out to our 24-hour helpline, and the many patients and the many families that we are working with directly about the challenges that they are experiencing getting care, getting support, in particular, getting an early diagnosis. There's a lot of uncertainty about the disease, lack of knowledge about the disease, where to turn for resources and services, when to reach out, and who do they reach out to? Are they reaching out to a primary care physician, or do they need to reach out to a specialist? So there's still a lot of work to be done in this area in terms of awareness. Next slide, please. So as we take a closer look here about the impact, this is a little bit more detailed data about the prevalence and the impact in diverse communities. And so we see in our Latino communities, the figures are expected to triple by 2040. Latinos are 1.5 more likely to have Alzheimer's disease and dementia, and Latino caregivers are spending a higher portion of their income and out-of-pocket costs to provide care. In our African American communities, again, we're seeing a significant impact that's going to be taking place by 2040, twice as likely to have the disease and also diagnosed at a later stage of the disease. Studies also predict that 36 to 39% of Black African Americans would be diagnosed with dementia within the next 25 years. For Asian American Pacific Islander communities, again, we're seeing staggering increases, and this is the fastest growing population in the United States. So something to really think about. The other is that a study in 2006 found that the community may not report symptoms of dementia to medical professionals unless family caregivers are requiring medical assistance related to behavior issues. And so that's something to think about as well. For our Native American Indian, Native American communities, again, we're seeing 1 in 3 American Indian adults that will receive a diagnosis in the next 25 years, and higher prevalence related to diabetes, heart disease, smoking, traumatic brain injury. For our LGBT community, we're also seeing significant increases and additional disparities related to higher risk factors. Also, 1 in 5 caregivers, there's significant care that's provided within the community itself. And caregivers and individuals who identify as LGBTQ are significantly less likely to access medical care and social services than their peers who do not identify as LGBTQ. 50% of trans adults report that they have taught their medical provider about transgender care, and 40% are not out to their provider. Next slide. Okay. When we think about gender disparities within Alzheimer's disease, in 2019 showed that 60% of Californians 55 years of age living with Alzheimer's were women, and predominantly the role of the California family caregivers are held by women, 59%. Of those that are married, 68%. So there's still a lot more that we need to learn about gender disparities in Alzheimer's disease. Next, please.
So
And here we
go ahead.
And here we can see broader data around the comparison between socioeconomic impact, risk factors, and the stages of diagnosis, which is going to lead to a deeper discussion with Dr. Winden. So Dr. Winden.
Sure. Thank you, Stella. So as I was mentioning, there are significant issues with regards to disparities in diagnosis. These disparities in diagnosis often fuel further disparities, particularly with regards to outcomes. The data on the right in the slide here is data from a study done of Medicare beneficiaries in California, where they were looking at the comprehensiveness of the dementia evaluation that individuals received, and also the timeliness of essentially the evaluation. So what they found was that only about 23% of non-Latino white individuals were actually first diagnosed at an MCI stage. If you look then at racial and ethnic breakdown, you see there are significant disparities with regards to African American, Latino, and Asian American individuals being diagnosed at an earlier stage of disease, with Asian American individuals being diagnosed at the lowest rates in terms of the MCI stage. Right below this is actually an assessment, again, from Medicare beneficiaries in this study, looking at the comprehensiveness of evaluation, where they found that only 10% of non-Latino white Medicare beneficiaries recommended all three elements of a diagnostic evaluation. These numbers were even worse for individuals who were Latino, African American, and Asian American. What's interesting as well is that in the research that has been done, we have come to understand that this extends far beyond just racial and ethnic disparities. Much is driven by socioeconomic status. And so some of these studies have been performed in other countries as well, where they found that underdiagnosis is lower in higher income countries, for example, compared to lower income countries. Even outside of the US, with the historical issues of the US in terms of structural racism, there are still racial and ethnic minorities that have disparities with regards to diagnosis compared to other groups. Next slide, please. So when we think about disparities in diagnosis specifically, it's helpful to conceptualize these different disparities as interlinked as part of a system. There are provider-related issues, patient-related issues, and then systems-related issues that all fuel disparities with regards to diagnosis. Some of the provider-related disparities include under referral to specialty care. As was alluded to earlier, we simply don't have enough specialists who are currently seeing individuals with cognitive impairment. But even beyond that, we don't even have efficient referral pipelines often to these dementia specialty care providers. Lack of education about clinical variation. This is a very common one where, for example, we know one of the common prodromes for neurodegenerative disease is new onset mood symptoms. So you may have an individual who comes into your office who's 45, 50 years old, no significant history of mood disorder, and they have all of a sudden crushing anxiety or tremendous depression. And oftentimes those individuals are not actually appropriately triaged or monitored. They have the beginning of a neurodegenerative condition, but there's significant clinical variation in their presentation because they're not coming in with memory complaints, for example. And then personal bias. Many of us harbor our own biases that we bring into the examination room with us, and those come out in our engagements with patients and often actually affect our decisions in terms of referral, etc. There are a number of patient-related factors. These stem largely from things including mistrust of the medical system. Many patients don't have an adequate education with regards to dementia and the warning signs of dementia and Alzheimer's, and then also a lack of access to health providers in general. This also is a little bit of a systems related issue, obviously, in that we don't have an adequate number of providers. But part of the systems related issues include inadequate time for evaluation in office. As a primary care provider, seeing somebody in follow-up for 10 minutes that you're allotted, it's oftentimes just not possible to go through the litany of concerns they may have about their cognition, particularly if things are subtle or they have very kind of different clinical presentations from what you might expect. And then finally, just an inadequate inadequate level of access to diagnostic resources, particularly some of the novel biomarkers for Alzheimer's disease, which are going to become increasingly important as we get into an arena where we have potentially actually therapies for these conditions. Next slide, please. So talking a little bit about cognition specifically, we spoke about diagnosis. We also know that there are disparities with regards to cognition. And these actually oftentimes influence not only diagnosis, but they also influence whether or not individuals are referred to research and other things as well. Much research has been done specifically comparing African American, Latino, and white individuals, which is a disparity in and of itself in terms of the research populations that are included. We'll talk a little bit more about that later. But we have found, though, is that when you look at performance on cognitive measures, specifically the bedside measures that we will often use in a routine office setting for the purposes of screening cognitive impairment, MMSE, MoCA, these measures are not culturally sensitive, which is a big issue. They're also not sensitive to things like language barriers and a number of other sociodemographic factors. And so what we have found is that Latino and African American individuals artificially score lower on many of these screening measures than non-Latino whites, up to a complete standard deviation. When you look at longitudinal decline, however, we find that the trajectories of longitudinal decline are nearly identical, even between the different racial and ethnic groups. And so the reason really this is important is because we are administering screening examinations in offices and providing people feedback, and they may be artificially scoring lower based on their racial, ethnic, sociodemographic background, and that is actually contributing in large part to a number of the disparities that exist. Next slide, please. So when we think about all of the different things that impact cognition specifically, again, we've talked a lot about racial and ethnic disparities with regards to cognition, but it's much deeper than that. Just because somebody's African American, just because somebody's Asian, just because somebody's Latino, there's no biological reason for them to have significantly worsened cognition compared to another group. It's really driven by the social determinants of health. And we've come to understand this over a number of years of different research. So the way we think about this is really multi-layered. So we can think about larger structural issues, and we can think about the most distally kind of mediators, the most distal mediators with regards to disparities. These include things like structural discrimination, racism, socioeconomic status, geographic exposures, immigration as well. Beyond this is more of an individual kind of mediator level where you may have psychological stressors. You may have test taking skills as well because of your ability to, participate even in informal education and possibly limitations with regards to that. Some of these feed more proximal mediators, which include things like medical access, physical health, health behaviors. Many of these individuals may not actually even have control over. For example, medical access is one in which an individual, depending on where they live, they may not have control over their medical access. We know the combination of these proximal, individual, and more distal mediators all impact cognitive function, all impact an individual's level of cognitive impairment, and ultimately contribute to this diagnosis of cognitive impairment. So it's a very, very layered approach when we think about disparities in cognition and all the different things that feed into that. Next slide, please. So one of the things to really emphasize is the importance of a number of structural factors that exist within the United States and other countries, but particularly the United States, that have a significant impact on disparities in Alzheimer's and dementia. One of the most important ones to talk about really is racism and discrimination. And so we know through a litany of research that structural racism is associated with numerous test findings. For example, we know structural racism has been associated with lower episodic memory score across different ethnicities on some of these more formalized testing measures that we've administered. We know also that wide range experiences of discrimination and lifetime experiences of discrimination again are associated with lower semantic memory compared to individuals who have not necessarily experienced this discrimination. Again, this is very much systemic and very much oftentimes institutional. If you look at the history of the United States, you come to understand that there have been historic practices like redlining that significantly affect where an individual lives, segregation in terms of schools. All of these have long-standing consequences in terms of cognitive health, and they're one of the major drivers in terms of the disparities that we see with regards to cognition, Alzheimer's disease, and dementia. Next slide, please. One of the things I really want to impart also in the brief time, that we're able to spend together today is that disparities don't start when somebody walks into the office with Alzheimer's and dementia. They start actually from birth. Number of studies have really demonstrated this. I've highlighted a few of them really to emphasize that from the beginning of essentially when we are alive, there are factors that we may face that actually contribute to disparities. Some of the more interesting things just to point out, so where you're born, first and foremost, there was a very interesting study that demonstrated if you're born in what is known as a high stroke mortality state, states like Alabama, Georgia, a lot of the southeastern US, if you're born in those states and are African American, you actually have a 9.5, 10 times greater incidence of dementia as opposed to somebody who was born outside of one of these states. Early life schooling is incredibly important. So we know there's significant disparities with regards to not just years of education, but quality of education. So being born and being, attending segregated schools in the southeastern US, you're going to have dramatically different educational experience compared to somebody who is born and attends non-segregated schools. It's even more so for individuals who may immigrate to the US, where your schooling system in your home country may have offered, significantly less in terms of educational opportunities compared to some of the schooling systems in other countries. And then also exposure to early life adversity. So being raised in a household that is socioeconomically disadvantaged as a child significantly impacts your dementia risk. By the time we get to midlife, there are very significant health conditions, medical comorbidities that often develop that will drive cognitive disparities. These have to do largely with vascular factors. So rates of hypertension, rates of diabetes, which in and of themselves are largely driven by social determinants of health. The fact that chronic medical conditions are more prevalent often among African American and Latino individuals is not by chance. It's often due, again, to these social determinants of health. But we know that these drive some of the disparities that we see later on in life. And then finally, just to finish off with late life, we know that a lifetime of exposure to discrimination and stressful events increases your likelihood of dementia. Dementia also, unfortunately, is a condition that contributes to decline of future generations even long after the individual with dementia has passed away. There was a study done where they demonstrated that comparing African American and non-Latino white households, African American households caring for an individual with dementia lost 94% of their household wealth by the time the person died, compared to non-Latino white families, which actually was closer to 65%, but still tremendous and substantial. Next slide, please. So with that, I will hand it back to Dr. Chodos to talk a little bit about really the critical importance of screening.
Thank you so much. And I'm guessing among the audience that you're absorbing a lot of what Dr. Winden was saying. I'm always amazed both with the way he and De La Peña present all this information and what is really an abundance of evidence that we have for the magnitude and some of the contributors to the disparities that we just went over. And I know for me, it's always a lot to absorb again. So I'll give you a moment to do so. And if you do have questions, again, encourage you to go ahead and put those in the chat so we can get to them at the end. I'm now going to take a little turn here and focus on some clinical tools. So as Dr. Winden was saying, why the importance of screening to address some of these disparities. There's so many places, of course, where better care, better systems, more education are needed. The focus of Dementia Careware in particular is on screening as a way to really, if you will, jumpstart our recognition and our ability to address dementia in primary care. I know I also said that I'm a geriatrician and I work at UCSF and in a dementia clinic, but I did do primary care for about 10 years after fellowship, and I do a co-management clinic in geriatrics with primary care. And so I have a lot of respect and admiration and hopefully adequate understanding still of what the primary care environment faces when thinking about approaching screening for dementia. So I'm slowing things down a little bit to allow us all to absorb some of the information I hope to present on screening that will be useful to you. We also have the slides. I really encourage you to download the handouts to either follow along or take a look at afterwards. And as with any presentation, when there's a lot of information, I'm going to just really highlight for you all what I really, really want you to take away, even as I add some nuance and additional information. But the really basic information is that we should be screening more routinely, as you see here, really everyone over 65. And there's very good evidence in many populations, particularly those that we were just discussing who experience disparities and in underserved, historically medically underserved populations, to screen earlier. But really 65 and older is a pretty good population-based strategy, given that the prevalence of dementia really jumps up for all race, ethnic, and gender groups at those ages. And then I'm going to present how we would approach screening that in a practical and systematic way. And that's one step. It's an equalizer, if you will. It may not address all the equity factors, of course, but it is a way for us to have more confidence that at least we're detecting earlier. Screening, of course, is not the same thing as diagnosis. The process of diagnosis can be a little longer, but we do want to at least start somewhere, and screening is a good place to start. The other thing about screening everybody is, as Dr. Wyndham was just saying, a lot of the tools that have been developed actually actively bias against certain groups and people with different educational backgrounds or who have experienced different socioeconomic and social determinants of health over a lifetime. However, we tried to pick tools for the screening that are less biased and a little simpler than others, so they're more doable and hopefully help us catch a broader population of folks who may be experiencing symptoms and need further workup. Okay, so with that, next slide, please. So if we can keep in mind a roadmap, I think we can all realize graphic design and illustration is not my strength, but I hope it gets across the general points that our big picture roadmap is we got a screen so we can detect early symptoms. Oh, it just told me I was experiencing some audio difficulty. My apologies. We need to screen, and when we screen and detect any symptoms, we can actually start with what we call a brain health plan or brain health maneuvers that can really help mitigate symptoms right away and help strengthen that person's cognitive performance right out of the gate. Then we're going to be working on next steps and understanding what else is going on if we can make a diagnosis, and if we have access to specialists. There may be moments where we want to do that. I'm not going to cover steps 2 or 3 today. And then step 3, of course, is if we've really gotten to the point where we feel comfortable saying this person has dementia, then what do we do and how do we care plan with that person? So that's the big picture roadmap. I'm sure it's familiar to you for many other conditions as well. And other big picture things to think about is all along, the second someone has symptoms, we're thinking about how can we support their brain health to help mitigate those symptoms and hopefully improve their cognition and function. What resources can we connect them to as soon as possible? And then finally, being open and having that conversation with folks about what we're learning as we're doing these assessments, how we can support them being a partner in the process and disclosing. That's a challenging issue in dementia for a lot of reasons. So really, I know that's a lot to take in. The Dementia Careware program is going to be kind of bringing out resources and highlighting other resources that exist and are fabulous, many of which have been developed by the Alzheimer's Association for things like diagnosis and disclosure and connection to resources. And today we're just going to talk about screening and detection. Next slide, please. So when I said screening and brain health kind of go together, if someone has a positive screen, we really want to start brain health maneuvers. Probably a good idea for anybody over 65 anyway, but if we had to be more judicious in the time that we spend making an effort to support brain health, it would be in people with symptoms. And it's really kind of ground level stuff that helps a lot of other conditions as well, and is really achievable, really doable, and active. So the big features of supporting someone's brain health, and the great thing about this is even if we get to a point of diagnosis where we say they have dementia and we maybe understand why, like they have had vascular conditions or Alzheimer's, something like that, we would still do all these things. So why not get started early? And what we recommend is correcting hearing and vision, reviewing medications for anything with cognitive side effects that could be reduced or removed, connecting them to social and physical activity resources, and managing blood pressure and diabetes, as is the goal with so much of primary care also. Next slide, please. Just want to make you aware the full training for this screening approach called the Cognitive Health Assessment is on our dementiacareware.org website. It provides 1.5 credits of CE, CME, and MOC credits. So feel free to sign up, it's free. Next. And it would look like this. You just have a couple of brief introduction and course evaluation at the end, but there's a roughly, on the very generous side, it's billed at 90 minutes, but particularly after today, it should take you much shorter time. And anyway, just want to encourage you to take that if that's useful to you. Next slide. Oh, thank you. Okay, so a lot of talking around it. What am I actually talking about? The cognitive health assessment. I think a lot of us think of dementia screening as just a cognitive tool, really just directly testing cognitive performance. Dementia itself, as I'm about to review, is actually a cognitive decline plus a functional decline. So we really wanted to upfront emphasize you need to screen both of those issues. So it's a way to quickly assess cognition and functional decline, as well as to assess the person's support system. The reason for that is obviously caregiver status is not a diagnostic criteria for dementia. However, it is so crucial to how we support people, how we care plan with them, that it's good to upfront start to understand and work with that information in hand. So it's a quick check on cognition, function, and support system. It's the start of a diagnostic assessment, but it's not the whole thing. Unfortunately, we haven't been able to find a way to make it that short. And then it's a jump start on brain health, as I already discussed. Next slide. So I wanted to just, again, remind everybody, this is one takeaway, if you can remember it. I know, I feel like so many of the tools are so focused on how to assess cognitive performance that it forgets to emphasize the crucial other half of a diagnosis of dementia, which is acquired functional decline. So dementia is a syndrome that we're trying to identify. It's not a disease in and of itself. The disease is what's underlying the dementia syndrome is usually what we're referring to as a neurodegenerative disease, a process whereby this person is losing brain cells. And that diagnostics process later is where we really try to understand if we can, if we're able to, either with, because of history and exam and the help of specialists if needed, if we can get to that place where we really understand what's going on in the background, great. But even then we can almost always acknowledge and recognize a dementia syndrome and start to work on a care plan with that person, even if we don't have quite figured out what the underlying neurodegenerative disease is. I'm not trying to minimize how important that is, but just to point out they're slightly different things. And to recognize dementia syndrome, we need to know if they have acquired cognitive decline in one or more cognitive domains and a functional decline. And then if you could advance, we also want to make sure that they don't have contributing causes that could be causing some of those symptoms. So I know most of my colleagues in primary care are quite good and quite immediately sort of look for other causes like thyroid disease, severe B12 deficiency, things like that, to look for causing and contributing factors. But the main big buckets are cognition and function, and that's why we include both of those in the screening assessment. Next slide. And then, and actually, never mind, I was gonna say you could advance, but hold on. I think it also just helps to know that it's a spectrum. So a lot of older people will present with cognitive changes because that's a normal part of aging related decline. And the other types of decline, however, are mild cognitive impairment and dementia. And really the distinguishing factor there is that there's been a functional decline in people with dementia. And I'll say a little more about what functional decline means as well in a second. And so it just helps to remember that cognitive symptoms are, we still have more work to do to understand, one, if they're in the abnormal range, and if they're associated with functional decline, to know where the person is on this spectrum of possible conditions. I also just want to point out, as we get older, we often have improvements in certain areas of cognition. And so it's normal, like all other organs, to have changes, but it's really about what kind of changes and how severe they are, how they're affecting your life, that really start to give you the characteristics of either a dementia or more milder syndrome like mild cognitive impairment. Can you advance, please? Okay, and then one more time. Okay, so and then age-related decline is normal. That's what's happening to all of our organs every passing second of the day. For the non-normal ones, it's mild neurocognitive disorder, major neurocognitive disorder are the new terminology for MCI and dementia, mostly to emphasize that these are essentially a spectrum of the same condition, which is presumably neurodegeneration and decline to abnormal levels. And those two are really separated by the functional piece, if there's functional impairment or not. Advance, please. Okay, and then as I already said, just to point out that dementia is a syndrome word diagnosis essentially, and it's a bucket term or an umbrella term, depending on how you like to use analogies and metaphors. And in that bucket are tons and tons of things. This is what Dr. Winden is a super expert in terms of figuring out which underlying disease could be playing a role, or what, which ones, because sometimes people have more than one. And we know that the most common neurodegenerative diseases that cause dementia are Alzheimer's disease and vascular disease in the brain. Lewy body dementia and frontal temporal dementia are also fairly common. And so these are the big ones. There's also Parkinson's disease with related dementia and many, many other types. And so it's just good to be aware. And the reason a lot of us think of dementia per se as memory loss and then, very slow decline and progression is because that's what Alzheimer's looks like. And it's the most common cause. But just to be aware that, especially in underserved populations, that may not be how people are presenting. They may be presenting more with behavioral symptoms, which is something that Dr. Winden alluded to. Okay, next slide, please. So how would you actually do the cognitive health assessment? And again, I'm going to go through this fairly quickly, and then just to keep it simple and hopefully you can take away what we're getting at. And then the actual application, of course, is harder. And we at Dementia Careware have some resources to support you in figuring out how to use them. We also have a warm line where you can contact us for support if you have a direct question about a clinical case or implementation. But the basic idea is we're going to be throughout looking for symptoms of cognitive and functional decline. How do we do that? We take a brief history, we use screening tools, and then, as we mentioned, we add on this element of assessing support system briefly. So it would be something like, do you have somebody who helps you with your medical care? Great, what is their role? What may record their name and number, or just confirm that that's what we have in the chart, for example. So it'd be something pretty simple. I'm going to briefly go ever so slightly into the next few, into each of these steps so that you get a sense, and then want to make sure we get back to the end of our presentation. So next slide, please. So the patient history, the reason for this, honestly, is because most of us do this in clinical practice. Some of us have regular screenings that are happening, like a survey every year for the Staying Healthy assessment that Medi-Cal had for seniors. Some of us are doing the annual wellness visit. So often these start with just a question: have you noticed changes in your thinking or your memory in the last year? The other thing is taking a simple history could be also your observation. I've noticed that they're having a lot more trouble remembering instructions, remembering medications, remembering appointments. That would be a check right there. You did it. You did the history. You know, you've identified a symptom. Next slide, please. The other piece is to consider using a tool. And what we've done here is given people options. I'd love to be more prescriptive because it might just be easier. But then again, you have your own practice and you have your own comfort level with what tools you want to use. And I would say the big takeaway here is we've given you some options that are free, really short, and come in multiple languages, the most common ones that we see in California for the most part. And what we're trying to do is we're trying to get one of the cognitive screening toolbox checked off and one of the functional screening tools checked off. And you could do these with either the patient or the informant. Of course, we recommend doing it with the patient, but at some point we also need informant information in this process, especially if they're positive. And for time's sake, sometimes you can be working with the patient on other things and the informant is doing these surveys for cognition and functional screening. So just want to give different options. And again, in our other materials, we're able to go in more detail. But I hope that you recognize some of these tools. One that I know most people don't recognize is the GP-COG. It's a 2-page assessment that includes for the patient and informant, and for the patient is the cognitive screen, and for the informant is the functional screen. And it was developed in primary care in Australia, and it's basically like the mini COG, which is 3 items, word recall and a clock draw. It's basically like that with a couple extra questions. So it's equally pretty short. If you could advance, and I'm sorry, there's going to be some animation. Yes, I was just trying to illustrate, you could keep going until it's over. I was just trying to illustrate that you can pick different combinations of things for what would work with your clinical workflow. Great, and this is an example of the GP-COG, which I know most people haven't seen before, but which I find fairly doable in a population that I serve, which is the most common patients we have in the older populations are non-English speaking patients, and often have less than high school education in non-US settings. So this seems to be a doable assessment with that patient population. So worth checking out if you feel you want to implement this. Next slide, please. And then functional abilities, I know many of us know this, but we have a checklist that you can go through with folks. And just to emphasize, this is what we mean when we say functional impairment. Do you have a change in the way you do these things, and have you needed more help over, X amount of time? That would be how we detect functional decline. This is kind of specifically what we mean are these instrumental activities of daily living and activities of daily living. Next slide, please. You can skip this slide. Thank you. And then the last one, as I mentioned, we know there are so many roles that people play in people's lives. Some are caregivers, some are just someone who knows the person and comes with them to appointments, or who can speak to how they're doing, like a roommate who maybe isn't directly involved but would be willing to talk to you about how that person's doing. Some people are formal healthcare agents. So just want to recognize there's a diversity of roles, and we can kind of ask people, if someone's not there, you can say, do you have somebody who's available to speak with me and knows you well? But you could also just say, do you have somebody who supports you in your medical care? Who is that person? Is it okay if I document that? Many, many times we have folks who come with someone, and it's okay to clarify what that relationship is and document. Next slide, please. Next slide, please. Sorry. Thank you. So just a quick review, and actually you can advance. I think the other thing about the way we structured this, which hopefully is helpful to you conceptually, is cognition, function, and social support end up being the domains that we come back to over and over and over again as we're assessing and supporting patients and their caregivers and care partners. If they have dementia, they will progress over time. And so we're going to reassess those things, how they're doing with regard to their cognitive functioning, daily functioning and support system, which changes a lot for a lot of people over time. So that's why we sort of structured it this way. And I hope going forward, that's a useful framework for you in terms of screening, diagnostic process, and care and support plan once someone's diagnosed. So now I'm very, very fortunate to hand it back to Stella and Dr. Winden to talk more about the future of addressing disparities in healthcare for people living with dementia. Next slide. And I believe, I don't know if your sound is turned on, that Ms. De La Pena was going to discuss representation in clinical.
Yes, thank you, Dr. Chodos. Yes,
Sure.
and so when we think about clinical trials, right, and think about, we've heard a lot today about disparities around Alzheimer's disease and dementia and the need for inclusion. And so when we think about representation in clinical trials, we know that there's limitations, right, in terms of treatment if we're not inclusive of all communities. Next slide, please. Okay, and so as we get closer to a disease-altering treatment, it's important to ensure that whatever effective treatments are on the horizon, that they're going to be accessible to every family member to benefit from the treatment. And the underrepresentation of racial and ethnic minorities in clinical trials, as we've been learning, we want to acknowledge that treatments, diagnostics that may be affecting these populations, we want to continue to keep working toward the availability and the inclusive representation for participants in trials. We see here that, 5% of trial participants are, less than 5% of trial participants are Black, African American, Latino, Asian American, Pacific Islander, and American Indian and Alaska Native. So there's definitely a lot of work in this area that needs to take place. Next slide. And here I will turn it over again to Dr. Winden. We've made some progress, but certainly there's a lot of work that needs to be done.
Sure. So I will quickly move through as I realize the hour is escaping us. So when we talk about elimination of disparities, I'm going to highlight really some of the larger, in my mind, more structural issues that continue to perpetuate disparities. There are obviously many layers to addressing disparities. We can't cover all of them, unfortunately, in this short time. But thinking about the big structural ones that have widespread impacts, a lot has to do actually with how we define diversity first and foremost. So in terms of defining diversity specifically for the purposes of research in Alzheimer's and dementia, we have continued to use essentially criteria that were set forth by the NIH almost 30 years ago, where ethnicity was broken down into Latino or non-Latino, and then race was broken down into Black, white, Asian, American Indian, Native Hawaiian, other. This is archaic, to say the very least. We know, especially in a state like California, with the tremendous amount of diversity, that this classification system just simply fails in terms of capturing the tremendous amount of racial and ethnic diversity that we have. Yet, again, this has been essentially our standard in terms of defining diversity for the very research that is intended to actually discover and understand how aging and dementia affects different populations differently. Next slide, please. So again, getting back to this idea of we need to do better with regards to coming up with better categories in and of itself. If you look at self-reported race and ethnicity compared to actually the NIH categories that I mentioned, this is a study done, the first line is from an electronic health record, a very large one. There is significant discordance between how individuals actually define themselves and how they actually are categorized in terms of race and ethnicity, up to 39 to 97% in some instances in some of these studies that they looked at. Again, also one of the very important things is looking at a state like California, where we have very interesting immigration patterns. The way individuals define themselves changes drastically depending often on their generational status. So individuals who are first generation compared to second, compared to even third generation, they may define their race and ethnicity completely different compared to the generations before themselves. Next slide, please. The idea of race and ethnicity, so these are different constructs. They're both social. There's no biological basis to them. I'll get to that in a minute. But we often lump them together as well. There are problems with this again, and the problem really is centered in we strip individuals of their diversity by lumping these two categories together. So lumping every individual who is Latino, for example, into a Latino ethnicity is tremendously problematic. It strips individuals of diversity with regards to language, with regards to immigration, with regards to socioeconomic status, with regards to culture. None of these things are accounted for when we use these very basic arbitrary labels. Next slide. And then the idea of we need to get away from ascribing biology to race. So as much as we have learned with regards to the field of genetics, this is still perpetuated each and every day in some of the most premier academic medical institutions. There are flawed understandings about race being intimately tied to biology. We know race and ethnicity are social constructs. And so we have to get our minds around the fact that yes, there are genetic factors, but human genetic variation is clinal. It doesn't drastically differ between somebody who's African American compared to somebody who's Latino, for example. We know that there is again clinal variation, and it's really the social determinants of health that drive so many of the racial and ethnic disparities that we see. So this is a particularly critical one to keep in mind, getting away from this idea of biology assigned to an individual's race. Next slide, please. Again, there are too many others really to discuss. A lot of the nitty gritty in terms of eliminating disparities, improving recruitment, more culturally sensitive providers and settings, more inclusive research. I emphasized and highlighted really some of the larger structural issues because I think we have to, in the back of our minds, while we're doing these obviously granular tasks, which are important on a day-to-day basis, we have to start conceptualizing and thinking about how can we make a larger impact and make a more tremendous stride towards equity overall. Next slide, please. And with that, I'll turn it back over to Stella.
All right, thank you, Dr. Winden. And so, certainly we've been talking a lot about, patients and support to families in terms of care. We also want to make sure that you are aware that we are available to help your patients and families. Once, you're actually working with patients and need to refer them to community resources. So we have a slew of resources available, everything from a 24-hour helpline to support groups, educational programs, early stage programming, and support for families in many, many different ways, and connections to local community resources. So please know that support is available. Next slide, please. And equally, there is support available to health systems. In addition to Dementia Care Aware, there is also additional comprehensive dementia care training programs such as Project ECHO, other CME programs that the association can assist with, and also support for those health systems that are considering age-friendly systems, which is a model of care that incorporates person-centered dementia care into broader frameworks around what matters most to patients. So lots of different support with practice change and best practices. So please definitely reach out. We also have a page on our website that is very supportive as well. Next. I will hand that over to Dr. Chodos to close us out, and here's a list of resources that are available.
Thank you so much. I honestly just want to thank you, Dr. Winden and Ms. De La Peña, for an amazing presentation and really how coherently you put together a lot of information. I want to really emphasize the Alzheimer's Association resources too, which are in the handout and I think really, really meaningful for patients, care partners, and health systems. Dementia Care Aware is here to support you. Our information's in the handout as well. So I'll let our presenter, Jen Turner, please finish up and thank the other sponsors of this event. Thank you so much for having us.
Absolutely. We have about 1 minute. There's a few questions. I don't know if it's going to allow us enough time, but I just wanted to ask if I might just choose one of the questions, which from the audience was just what is a simple example of an early sign of functional decline? So I don't know if there's a very succinct response to that, but thought I would pose that question.
Yeah, probably the earliest one is difficulty with forms and financial information. That tends to be one of the earliest signs. So people lose functional abilities, typically instrumental activities of daily living, like complex tasks, bills, cleaning, cooking, shopping, before they lose things like being able to dress and bathe. So it tends to be stepwise. But the earliest sign, often 6 to 8 years before diagnosis, by some really impressive research, is financial abilities. So if people are having trouble paying bills, someone else has had to take over, or they're making mistakes, those are the kind of questions I ask about.
Terrific, thank you. And as displayed here, the website information or contact information is available for Dementia Aware Care as well as the speakers. And so if you certainly would like to ask your specific questions, if we were not able to get to them, please do. We'll keep this on the screen for just a few moments. Wanted to take the time to thank all attendees for joining this very important and informative webinar today. We recognize you are all busy and we appreciate you carving time out of your day. Also want to take the time to recognize our speakers again, Dr. Windun, Dr. Chodos, as well as Stella De La Pina. Very good information, and we really certainly appreciate the partnership with you. So this information will be posted on the Physicians for Healthy California website. For those who have registered and attended today, you will also receive a link of the recording, so you'll be able to refer to it or share it with others. Again, thank you for joining the webinar, and this concludes our time today. Have a great day.
Happy holidays.
Bye, everyone.